Hello, everyone. We'll be presenting a suicide prevention program in military veteran population. It'll be presented by Rebecca, Margaret, and Tajee. Next slide. Military veterans make up about 7.6% of the U.S. population. So when civilians join the military, they become a part of a team. They place their lives in harm's way, working and living for the shared purpose. Many veterans transition back to civilian life have difficulty due to multiple factors, such as feeling lonely, being left without a team, not having the family support or a support system in place. And then also, a lot of veterans suffer with poor help-seeking behaviors due to like stigma, the military culture of stoicism, and even concerns about healthcare professionals being able to understand them and understand the problems that they're going through. The military veteran population is made up of individuals, 27.1% of individuals that identify as non-white, 64.5% are aged 55 and older, and 88.6% of veterans identify as males compared to 11.4% that identify as females. Within the military population, women have a higher prevalence of both depression and anxiety compared to the males. But this also could be due to poor health seeking behaviors of the male veterans due to stigma or and it not being reported. Suicide count, military veterans account for 14% of adult suicides, and military veterans also have a 1.5 higher rate of suicide. And females have a 2.1% higher percentage compared to males when it comes to suicidal behaviors. Next slide, please.
When we talk about risk factors of suicide for veterans, we see that PTSD, post-traumatic stress mental health condition after exposure to traumatic events is very prevalent. Uh, uh, Bouts with depression and anxiety, abuse of alcohol, death of a loved one, physical health problems, and mental health problems, prior suicide attempts, stressful life events like I said, death or divorce, and access to guns and certain medications makes and lifetime full of trauma makes a veteran more in risk of committing suicide. Next. And when we talk about protective factors, being connected, feeling connected with the community or just with people in general, access to healthcare, that's very important, especially in areas where there isn't a lot of access to healthcare. Um, Anything you'll see what we're going to be doing. Positive coping skills, spirituality or religiosity. Some people are religious and some people are spiritual. And like I said before, family and support, social support, is very good factors for making people not want to commit suicide or thinking about something else. Sorry.
The psychological impacts of both suicide and homicide have profound and far-reaching psychological consequences on the individual, their family, and the surrounding community, particularly within the veteran population. Veterans who attempt to complete suicide often suffer from untreated or complex psychological issues such as PTSD, depression, moral injury, and traumatic brain injury. The act itself stems from a perceived loss of purpose, chronic pain, or alienation, particularly during reintegration into civilian life. Families experience acute grief reactions compounded by guilt, anger, and confusion. Many survivors of veteran suicide report complicated bereavement, depression, and increased risk of mental health disorders. Community-wide, a veteran's suicide can destabilize social networks, prompt vicarious trauma in fellow service members, and erode public confidence in veteran support systems. These ripple effects emphasize the urgent need for comprehensive trauma-informed prevention and postvention programs. And so we created Valor Link. There we go. Our group proposes a hybrid, community-based suicide prevention program designed specifically for military veterans, and it's called Valor Link. This program will serve as an adaptable model within regions, particularly in rural or suburban or urban settings with high veteran populations. And offers both walk-in and call-in services, supplemented by telehealth and online chat options to overcome transportation barriers and reach isolated veterans. The mission of Valor Link is to provide accessible, trauma-informed, culturally competent care that prevents suicide and promotes post-military resilience for veterans and their families. The program will partner with local VA clinics, faith-based organizations, veteran peer support groups, and community health providers. Services will include crisis stabilization, individual and group therapy, peer membership, family education, and linkage to housing and employment support. Outreach will also focus on postvention services for families and communities impacted by veteran suicide. The delivery of Valor Link services will be grounded in trauma-informed care principles, safety, trustworthiness, collaboration, empowerment, and cultural responsiveness. Our team will employ evidence-based assessments, such as the Columbia Suicide Severity Rating Scale, or the CSSRS, and the PTSD checklist for DSM-5, the PCL-5, to evaluate suicide risk and trauma exposure. Immediate crisis intervention strategies will include the use of crisis response planning and safety planning interventions to tailor veteran-specific support, and will integrate cognitive processing and narrative exposure therapy, which are effective in reducing PTSD symptoms and reconstructing meaning after trauma. So there are the assessments we will utilize and the interventions. Veteran peer specialists will be trained to co-facilitate support groups, offering relatable insight and modeling help-seeking behavior. As with the previous slide, all staff will undergo training in military cultural competence and training stewardship to ensure care is respectful, non-pathologizing, and empowering. There are special considerations if a veteran has been deployed for multiple deployments. They are at heightened risk of complex PTSD, accumulated stress and isolation, and family fatigue and emotional detachment. Because of this, there needs to be long-term support and care. So throughout the use of multiple deployments, there must be consistent mental health care. I'll note that telehealth care, if someone is overseas, while it can be difficult with time zone changes, is a method of being able to do that consistent mental health care. And then there needs to be ongoing community reintegration assistance. Cultural values affect the following: emotional expression and coping styles, attitude toward mental health services, help-seeking behavior, importance of cultural humility and tailored communication, and respect for veteran identity and service-related values. These are important to include in the continuum of care.
ValorLink seeks to address these cultural factors by providing services in both the rural and urban neighborhoods to allow individuals with lower socioeconomic status to utilize the program and the resources available. Some of the factors that might how we will address those to make a more culturally competent practice and to practice cultural humility is by including some of the idioms of distress within like the intake form, because 27.1% of veterans identify as non-white. So they express suicidal distress differently, and having these symptoms listed on the intake form will allow people to identify their symptoms that align with their cultural values and beliefs. Also taking into account minority stress and discrimination, while clinicians should keep that in mind while seeing the diverse population, because they might have a mistrust for government and state agencies due to past experience or past discrimination. So providing them the option of being able to like walk in or call into the office provides them with like a sense of control and allows them to be treated with the dignity and respect that they deserve without fear of discrimination and not receiving services. Another factor is addressing stigma and help seeking behaviors. Some cultures believe that seeking outside help is seen as weakness, but working with people in the community to spread awareness and help them and help destigmatize and normalize mental health care within that community will allow them to be more willing to participate in services and not feel ostracized. So I think simply teaching individuals to recognize that they need support, helping them find it, and enabling them to reduce their suicide risk. So taking all these cultural factors in place, ValorLink will be able to provide culturally competent care while teaching cultural competency to individuals.
How are we going to evaluate the program effectiveness? The most important thing.
All you people do is steal.
Oh Lord, I'm sorry. Oh, the most important thing is to lessen the suicidal ideation, and we're going to do that by measuring that. Because through our goals and objectives, we're going to measure the outcomes by using the CSSRS along. I said that twice. Along with the VEX scale of suicidal ideation. On top of that, we're going to see if we've also lessened their level of depression through the PH9 and their anxiety through the PCL5. We also will be taking interviews of clients and their family member outcomes. So that's step 1 through 5 through 6. So we're gonna have clear plans and goals and objectives. We're gonna follow them. We're gonna measure the outcomes. We're gonna use the different methods I spoke about, and then we're gonna consider all the outcomes, just in case there is some negative connotations behind some of our intake. And we're gonna engage the community involved in the suicidal, the people who want to commit suicide and their family members. We're going to analyze the data and we're going to give it to whoever needs it so they can do better in the field of helping these veterans. And our assessments are on the on after the on the appendix. Blah 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 blah. Thank you so much.